And moderating will be Diane Gray, who is the Chief Innovation and Advocacy Officer at the Acclivity Health Solutions and also a board member of the Elizabeth Kubler-Ross Foundation. So, Diane.
Hi, and thanks for staying the distance with us. We know you have a lot of choices to make today, and especially you have the choice to bolt in face of the storm. So we're going to try to keep this session concise, but also this is a very important issue. I mean, the topic of this session is grief after we die. But I can also share with you that I believe, and I believe that others do as well, that we grieve while we live. We don't just grieve after the death of someone. We grieve every day in some way, and we also grieve throughout illness. We grieve throughout prognosis and diagnosis. We grieve in so many ways. I think it's a time to, as part of our culture, to recognize that grief is a very important part of life. And for many, as we'll hear today from Carrie Keyes, it's a part of epidemiology. We'll also hear from Susan Muzrachi that it's a part of our literature and it's a part of our core. And also, too, we're going to hear from Chris Gill about a fascinating project that he's doing in Lusaka. So I'm going to invite each of the panelists up here and to join us. And while they're coming up, I'm going to tell you just a very brief story. So yes, I am the spokesperson for the Elizabeth Kubler-Ross Foundation, and I do speak and teach on behalf of Elizabeth. But I'm here too as a bereaved mom. My son was diagnosed with a rare neurological disorder at the age of 4, turning 5, at a time when we had no advance notice and no warning that this was a part of our genetic makeup. And everything was all fine and well in our lives until they told us at 3, turning 4, that my son had retinitis pigmentosa, but it was part of this larger neurodegenerative disorder called neurodegenerative brain iron accumulation. In short, Austin lost the ability to move a hand and then a leg and then an arm and then walk and then talk and then swallow and then eat and so on and so on. Eventually at age 9, Austin became a hospice patient, and prior to that, a palliative care patient, and we were a 5-year hospice family. Austin did become tube-fed at the age of 5. We had no idea. We thought we were part of those families that everyone's been talking about today, that something magical would happen or there would be some cure. And I want to thank all of you as participants today and as leaders in these panels for giving serious thought to this issue, because we tend to think, and I'm looking for the person that I spoke with yesterday who was 36, who said, I don't have an advance directive, why do I need one of those? Because life happens. It happens to all of us. It happens to our children. It happens in car accidents. It doesn't just happen in the event of rare disease or illness or cancer or any of those all the time. So if you don't have one, please get one. And on the topic of my son, what happened was we were a 5-year hospice family, and eventually I did have to go through some of the medical ethical decision-making processes that we've discussed, because we did have to remove, or we chose, I should say, to remove Austin's feeding tube, and the removal of nutrition and hydration was a part of our journey. It took 18 days. It was a peaceful passing. We did it with hospice's assistance. So as a surrogate decision maker, I did make that decision, and Austin was cognitive at end of life. It was a team and family decision. And I want to thank all of you for digging deep and asking these questions. This is where change happens. So also, too, with that in mind, I'm going to ask you to open your minds and your conscience and your hearts and your souls to have this conversation on grief today. And here's why. When we look at the resources for grief and bereavement in our country, it's very simple. There simply are not enough professional resources to meet the need of the grieving in our country, much less the needs of the grieving globally. So with that said, even with those resources, the average cost for someone to get professional grief counseling is in the area of $125 to $175 per hour. So what happens? They don't go. So then we have this pervasive nature, right? First of all, we have stigma and shame and guilt surrounding end of life, death, but also grief, especially in America. And especially over things like so-and-so's pet died, which in this country may seem like a silly thing, but we know that pets and pet loss are a part of the framework of families and a part of many family structures. It's just part of the grief experience that we also need to expand upon. And also, too, I'm going to ask you to consider, too, the content within part of this conversation in its sum today, that we look at it and we say, you know what, how can I get involved? Because there are not enough professional resources as doulas, end-of-life advocates, clinicians, and so on, and that includes in the arena of grief and bereavement. We're seeing more and more movement of doulas, and there is talk now of an undercurrent of a grief doula movement. It needs to happen. And at bare minimum, we need to be better educated, all of us, in how to be with grief, not just treat grief. Grief is not an illness. Grief is a part of life because we love. So on that note, I'm going to invite Susan to come up and start our session. Thank you.
Okay, just make sure. Oh, good. All set. So I press. Okay, I hope that I can figure this out. Doesn't look too difficult. Let me first just thank Sandro for organizing yet another wonderful conference and for inviting me to speak here. And I want to also say that my colleague, Professor Amy Appleford, provided actually a perfect introduction to my talk in her answer to the last question at her panel. So I'm going to be talking about the literature of grief, as you see here. John Keats's Ode on a Grecian Urn, Emily Dickinson's I Measure Every Grief I Meet, Gwendolyn Brooks's The Mother, Michael Harper's Nightmare Begins Responsibility, Primo Levi's Survival in Auschwitz. There is probably no creative form that has devoted more thought to the experience of loss and mourning than literature. My talk today explores the role great literature can play in providing access to what we might call the varieties of grieving experience. My examples will be works by Ralph Waldo Emerson, William Faulkner, and Toni Morrison, each of which plunges us into the throes of loss and mourning and eventually guides us out. By representing the unique and powerful suffering of different kinds of mourners and their various means of survival, Emerson's essay Experience, Faulkner's As I Lay Dying, and Morrison's Beloved represent how the overwhelming isolation conferred by confronting death up close can be alleviated and bridges built from the sufferer to the wider community. Let me emphasize that I am not suggesting that in any of these works, grief is a condition that is overcome, but through its translation into language, it sparks, reaching beyond those possessed by it, becoming in some sense the possession of the community of grievers, which we are all members of at some point or other. I've been a member myself pretty relentlessly in recent years. In 2011, the family pet, a Portuguese water dog, died. In 2014, my husband of 29 years died. And last spring, 2018, my mother and father died within 7 weeks of each other. I tell you this not to make myself sound pathetic or invite sympathy, but to confirm that I am no stranger to grief. Because I have always been a reader and been surrounded by readers in my parents, my husband, even the dog whose name was Harry Potter had literary aspirations, I naturally turned to books to deal with loss. I read everything I could find, philosophical, psychological, medical, from classic to contemporary. enough to convince me that for dealing with grief, nothing beats literature. What benefited me further was the fact that as an English professor, I make my living teaching great literature, a significant proportion of which concerns the subject of death. In the wake of each loss, inevitably, I found myself in a classroom teaching experience, or as I lay dying, or beloved, to a group of students. I never told them what I was dealing with myself, preferring simply to be part of a group, interpreting accounts of the ultimate estrangement, at once so grim and remote, yet so common. Yet it was clear to me that firsthand experience had changed my understanding of works I'd been teaching for decades. For grief is a teacher too, a far more profound and comprehensive one than I'd ever been. Prior to these harsh one-on-one tutorials, everything I had read about grief had been, or at least seemed to me, hypothetical. In the 1844 essay Experience about the death of his 6-year-old son, Waldo, the American writer and philosopher Ralph Waldo Emerson seems to be at war with grief itself. People grieve and bemoan themselves, but it is not half so bad with them as they say. There are moods in which we court suffering in the hope that here at least we shall find reality, sharp peaks and edges of truth, but it turns out to be scene painting and counterfeit. The only thing grief has taught me is to know how shallow it is. That, like all the rest, plays about the surface and never introduces me into the reality, for contact with which we would even pay the costly price of sons and lovers. Grief, too, will make us idealists. In the death of my son, now more than 2 years ago, I seem to have lost a beautiful estate. No more. I cannot get it nearer to me. If tomorrow I should be informed of the bankruptcy of my principal debtors, the loss of my property would be a great inconvenience to me, perhaps for many years, but it would leave me as it found me, neither better nor worse. So is it with this calamity. It does not touch me, something which I fancied was a part of me, which could not be torn away without tearing me, nor enlarged without enriching me, falls off from me and leaves no scar. It was caducus. I grieve that grief can teach me nothing, nor carry me one step into real nature. Why, the literary critic Sharon Cameron asks in a remarkable analysis of Emerson's essay, does Emerson seem, quote, to mourn the lack of his affect more than the loss of his son? She goes on to discuss the essay as an elegy, which represents the very work of mourning. Grief is neither given into nor given up. For Emerson, it is boundless, the begetter of everything. The answer to the question asked of all students reading Experience, where is Waldo, whose death is only mentioned this once, is Waldo is everywhere. Yet however much we might explain Emerson's perspective psychoanalytically, there is no minimizing his principal complaint, that grief reinforces our fundamental distance from everything we experience. I had always taken Emerson's lament for granted, persuaded by his conviction that losing someone intimate to the alien territory of death could not bring death closer, but only reinforce the ultimate human alienation, even from our sorrows. But my own experience contradicted that. For me, confronting the deaths of people I loved whose lives were completely wrapped around my own did serve to familiarize death. In fact, I found my lifelong fear of death and of many other things considerably reduced in the aftermath of overwhelming loss. Another work I understood differently, was Faulkner's As I Lay Dying. The novel tells the story of a mother, Addie Bundren, whose death and burial provides its centerpiece. Retrospectively, through the voices of her husband, children, and neighbors, the story of her harsh rural life is told, a life about which she says, quote, "The reason for living was to get ready to stay dead a long time." The novel portrays death as a journey, including the journeys the living must take to accommodate death emotionally. This partly explains the novel's language, formal, elevated. Confronting death transports survivors, providing access to linguistic depths they couldn't otherwise access. Faulkner both speaks for his characters and represents their mental shifts to a universal plane of meaning. Mourners are separated from the living, set apart, contaminated by their brush with death. Yet mourners also remain selfishly aware of their triumph in outliving the dead. Faulkner's characters display both aspects of mourning. During their trip to Jefferson, carrying their mother's rotting corpse on their wagon, they elicit disgust as much as sympathy, a vivid reminder that in the most primitive terms, the state of mourning is polluting. But everyone in Addie's family also harbors a secret goal for the journey. Each of them wants something in the town of Jefferson. The father covets new teeth. One son desires a phonograph, another a toy train. Analysts of As I Lay Dying emphasize how ironic it is that Addie Bundren's last request is so devoutly honored by her family. For Addie has committed adultery, and the son she loves most, who she names Jewel, was fathered by the town minister. Moreover, Addie passionately denounces language, the capacity of words to express feelings, which again complicates her survivor's adherence to her burial wish. But the biggest question of the novel remains the symbolic import of the arduous journey itself. Why does the mother send her family all the way to the state capitol to bury her? The death of my own mother changed my view of this pivotal detail. Addie makes this request because she is a mother, doing what mothers do, giving birth and sending the people they love on the journey of life. It is the role of mothers to encourage selfishness, greed, shoving their offspring from the nest by enabling the aspirations that will take them beyond it. Moreover, Addie understands that it is hard for mourners to let go of grief, and ways must be found to return them to the fold. No one understands this better than Toni Morrison, who in her novel Beloved, which is dedicated to the 60 million and more victims of the slave trade, imagine mourning as a ghost story, with a grief-stricken dead baby haunting a grief-stricken mother. What happens, the novel asks, when a victim, a slave mother viciously abused through her very maternal faculties, becomes a victimizer, killing her baby in order to prevent her capture by slave catchers? The novel asks us to consider infanticide as a form of maternal protection, though it features many characters who reject this possibility. Like Emerson, Morrison depicts grief as a complexly ambivalent but all-encompassing condition. Both mourners are represented as aggressors, the mother who has killed her baby and the baby who returns to haunt the mother. The dead are everywhere in the novel's world, their omnipresence a metaphor for the continuing impact of a slave system that haunts the post-emancipation context of the novel's setting, as well as the 1980s context of the novel's writing. According to the grandmother, Baby Suggs, quote, Not a house in the country ain't packed to its rafters with some dead Negro's grief. Oh, I'm back to the beginning. Here is the novel's opening. 124 was spiteful, full of a baby's venom. The women in the house knew it, and so did the children. For years, each put up with the spite in his own way, but by 1873, Setha and her daughter Denver were its only victims. The grandmother, Baby Suggs, was dead, and the sons, Howard and Bugler, had run away by the time they were 13 years old. As soon as merely looking in a mirror shattered it, that was the signal for Bugler. As soon as 2 tiny handprints appeared in the cake, that was it for Howard. Neither boy waited to see more. Another kettle full of chickpeas smoking in a heap on the floor, soda crackers crumbled and strewn in a line next to the door sill. Nor did they wait for one of the relief periods, the weeks, months, even, when nothing was disturbed. No, each one fled at once. The moment the house committed what was for him the one insult not to be born or witnessed a second time. It's supposed to have the text. The house, 124, is aptly numbered to highlight absence. The omission of the 3 in the sequence 1, 2, 4 is a convenient reminder of Setha's 3rd child, the baby girl ghost. Avenging its own violently abrupt end, the ghost spurs the exit of every family member who can flee. Awesome in its puny wrath, the ghost has made home, the place of shelter, menacing. What is this, if not the fantasy of every offspring, to have the mother all to itself, swallowing and being swallowed in a dream of total unity? Hence, the abundance of food imagery, signifying an insatiable orality. Of course, this particular narcissistic infant has a legitimate bone to pick, and its return, seeking nourishment, is heartbreaking. The tragedy is that she will never grow up, never overcome her need, but remains trapped forever in a boundless temporality, not unlike death itself. Grief in Beloved is also limitless because the mother is traumatically responsible for the loss she mourns. Morrison manages to universalize a profoundly alienating act of infanticide by enfolding grief in guilt. An all too quiet dead son, an all too vibrant dead daughter, a family dismembered and reconstituted on a burial journey. 3 epic US examples from the literature of grief. Thank you.
Thanks so much for the invitation to speak today, and to Sandro for inviting me. I'm going to provide somewhat of an epidemiological perspective on the incidence and prevalence of psychiatric disorders during and after intense periods of bereavement. And this is a really fraught topic with a really fraught history in psychiatry, because the question is, you know, to what extent is bereavement pathologized? Obviously, the loss of a loved one is, many people experience it. It's a really central part of our human condition. And bereavement, intense bereavement and intense sadness after the loss of a loved one is expected. It's a natural part of that process. And so there was a lot of effort on the part of psychiatry to say, okay, we don't want to pathologize this natural part of the human process, this grief and bereavement period. So in DSM-4, the Diagnostic and Statistical Manual of Mental Disorders, there was an exclusion where you could not diagnose, even if someone met criteria for a disorder such as major depression, which is characterized by intense sadness, problems eating and sleeping, and feelings of suicidal ideation, that even if you meet those criteria, you can't make a diagnosis of major depression in the wake of a bereavement, because that shouldn't be pathologized. That is part of the human condition. But then there was really a pushback against that notion, especially on the part of clinicians, to say, there's a lot of people who are in intense need for services while they are grieving. And so actually not allowing a major depression diagnosis during bereavement is arbitrary, when someone is experiencing a lot of distressing symptoms. Furthermore, there is a lot of traumatic events that people endure where they have natural and expected symptoms of depression that we don't have exclusions for. You know, if you lose your job, you're going to grieve and have a bereavement period. Should that not be diagnosed as major depression? So in DSM-5, they removed the bereavement exclusion from the major depression diagnosis, still with a lot of controversy around it. And you know, just to quote one person involved in the diagnosis, who was quoted in 2004, saying, "No, we must not medicalize normal grief, but neither should we normalize the serious disorder of major depression simply because it occurs in the context of a recent bereavement." So with that sort of frame, I wanted to present some of the literature on the actual occurrence of psychiatric disorders among bereaved people. And there's two major groups that have been studied epidemiologically for the occurrence of psychiatric disorders during bereavement, and that's children and widows in later life. So I'm going to present just a few exemplar studies of those two groups to kind of get us started. And I don't know if you can see this that well, but the Great Smoky Mountain Study is a longitudinal epidemiological study of people in the community. And it happened that in this ongoing longitudinal study, there were quite a few children who experienced parental loss and other types of bereavement conditions. And the study was incredibly well done in terms of their ability to document the occurrence of psychiatric disorders. Again, not children who are clinically ascertained or clinically referred, but interviewed in the community setting about their psychiatric disorder symptoms. And essentially, what is shown here is actually two different time periods. On top is the incidence, so this is new onset, people who did not have, children who did not have disorders before. The incidence of psychiatric disorders right during the time period, the same interview where they reported a parental loss. These were the occurrence of psychiatric disorder symptoms. And below is the occurrence, the new onset of psychiatric disorder symptoms at the next wave, so about a year and a half later. And so essentially what was shown on top, those three different columns control for different factors, because it turns out that kids who experience bereavement are different than kids who don't experience bereavement in terms of parental loss. Those kids are more likely to be in poverty, more likely to have other traumatic events that occur. And so even when you can control for psychiatric, for sociodemographics, previous psychiatric symptoms, essentially what that table shows is that those children were more likely to experience generalized anxiety, separation anxiety, conduct problems, depressive disorders, and that occurred, for most disorders, it really occurred whether or not the loss was parental or another very close relative. That intense period of bereavement was associated with the onset of these psychiatric disorders for those children. And then what the bottom shows is that persisted a year later. So those kids were then more likely a year and a half later have generalized anxiety disorder, separation anxiety, conduct problems, and that was particularly heightened among kids who lost a parent. And then substance use disorders and PTSD as well. It's also been shown that kids who lose a parent suddenly or unexpectedly are at even higher increased risk for the onset and incidence of psychiatric disorders. So this is a study that was published in 2008 that used epidemiological methods to ascertain a sample of bereaved children who lost a parent through unexpected means, and then compare them to randomly selected comparison groups, again, interviewed in the community, not clinically ascertained. So these are kids who lost a parent due to suicide, an accident, a comparison group of kids who lost parents due to quote-unquote natural causes, and then controls who were non-bereaved children. And really across the board, kids who lost a parent suddenly or unexpectedly were more likely to have depression, PTSD, and a range of anxiety disorders, and just lower rates of global functioning in general. And that, again, occurred both in the offspring themselves and among their caregivers, who had also experienced that loss. So the incidence of psychiatric disorders is higher among these children, both in the time period of the bereavement, later on in childhood. It occurs among their caregivers as well, and it occurs more frequently when that loss is sudden or unexpected. The other group that's been studied very extensively in terms of, again, incidence and onset of psychiatric disorders during acute periods of bereavement are widows and widowers. There have been several actually reviews and meta-analyses of psychiatric epidemiological studies that have looked at the incidence of psychiatric disorders. And you know, again, these are not natural and normal symptoms of bereavement, but you know, clinical diagnoses indicative of impairment and bereavement. So these are all the different studies that have looked at the incidence and prevalence of mood and anxiety disorders among widows in older age. There are studies that have looked at both screening scales for cutoffs on depression and anxiety and those using clinical diagnoses. These are all the studies that have looked at depression. These are all the studies that have looked at anxiety disorders. Essentially what these studies show is that in the wake of the loss of a spouse, the prevalence of mood and anxiety disorders when measured by screening scales is around 50%, and when used clinical diagnosis around 25% for depression and around 25% for anxiety disorders as well, and this is higher than the general population. So we have these various studies at these kind of endpoints in the life course, and we were interested in really kind of documenting the incidence and prevalence of psychiatric disorders across a broad range of the life course. And so I undertook a study several years ago with Dean Galea in this room and others looking at unexpected death of a loved one and the occurrence and incidence of psychiatric disorders really at every point in development. So I wanted to go into some detail about the study itself. We used a study called the National Epidemiological Survey on Alcohol and Related Conditions. And again, what's I think important about this for an epidemiological context is that it is a large survey of people ascertained in communities. It's not people who were referred to treatment or people being seen by clinicians, but people interviewed about their psychiatric disorders and the occurrence of psychiatric problems in their homes. Most of whom had never seen a mental health professional. There were two waves of the NESARC study. The first one had 43,000 people. 34,000 of them were re-interviewed approximately 3 years later. And at that wave 2 interview, people were interviewed about their potentially traumatic experiences, including 2 questions that assessed unexpected death of a loved one. Did someone very close to you die in a terrorist attack? And then, not counting a terrorist attack, did someone very close to you die unexpectedly? For example, they were killed in an accident, murdered, committed suicide, or had a fatal heart attack. Among those who reported that experience, they were asked about the age in which it first happened and the number of times that it happened. Elsewhere in the interview, there was a lay-administered structured interview for a wide range of mood and anxiety disorders, all of which have well-documented reliability and validity compared to other lay interview administered structured instruments that are done in epidemiological studies. So psychiatrists aren't making these diagnoses. A person with no mental health training is administering an instrument that assesses symptoms that can be then mapped through algorithms onto DSM-4 diagnoses. So 50% of this nationally representative sample reported that they had experienced the unexpected death of a loved one. It was the most common of all of the potentially traumatic events that were assessed. And because it was the most common, it's probably not surprising that of all the cases of PTSD that we assessed in this epidemiological study, the modal cause of PTSD was unexpected death. So 27% of all cases in the nationally representative sample were due to unexpected death of a loved one. We also looked at, so what the survey did was, you went through this entire battery of potentially traumatic events, and then they said, well, what is the worst one that you experienced? Among people who experienced more than one potentially traumatic event, what was the worst one that you experienced? And then they assessed PTSD for the thing you say is the worst thing that you experienced. And so we looked at the number of lifetime potentially traumatic experiences that people reported and the probability that they reported that the unexpected death of a loved one was the worst one that they experienced. So among people who had one or more, 30.7% said that unexpected death of a loved one was the worst. And as you go down, so these are people who are experiencing 3, 4, 5, 6, 7 really traumatic experiences, including violent attack and assault, all ranges of traumatic experiences, and unexpected death of a loved one was still most frequently cited as the worst. Even among people who had 11 or more potentially traumatic event experiences in their life, 21.6% of them still reported that unexpected death of a loved one was the worst thing that they experienced. So then we wanted to know whether the incidence of psychiatric disorders was heightened at different points in the life course depending on the experience of unexpected death of a loved one. So what is shown here is just the age of the average age of onset of depression across the life course. So major depression, the incidence of major depression increases during the transition to adolescence. The incidence of major depression is the highest in adolescence and early adulthood, and then the incidence of major depression then declines throughout the rest of the life course, and then there's a small peak in major depression incidence after age 70. That's for the whole sample. Now, if you overlay on top of that the same incidence curve, but for people who experience unexpected death of a loved one for the first time between age 15 and 19, that's what it looks like. So there's a huge spike in the incidence of major depression at the age of 15 to 19 when you also experience unexpected death of a loved one for the first time at age 15 to 19. What about other points in the life course? These are the same incidence curves if you experience unexpected death of a loved one for the first time at age 35 to 39. There's a huge spike in the incidence of major depression if that's the first time you experience unexpected death of a loved one. There's a huge spike if you experience unexpected death of a loved one for the first time between age 60 and 64. And almost all cases of major depression that occurred for the first time after age 70 occurred in the wake of an unexpected death of a loved one. And in fact, then if you just add in every single age group, you can see that unexpected death of a loved one increases the incidence of depression when you experience it for the first time, no matter where in the life course it occurs. No matter whether you're a child, a young adult, in middle adulthood, in older adulthood, the incidence of major depression increases. And in fact, the incidence of a whole lot of things increases in the wake of unexpected death of a loved one. So these tables show numerically what I showed graphically for major depression, but you can read the paper and look at all the different psychiatric disorders that we looked at. But here is major depression. These odds ratios above 1 indicate an increase in the odds. So every single age group in which unexpected death of a loved one first occurred, the incidence of major depression was significantly increased subsequent to that major depression. Also, we observed increased odds throughout the life course for disorders such as dysthymia. We also observed increased odds of manic episodes, especially those occurring later in life, and I'll return to that in some discussion. Alcohol use disorders was less associated with increased incidence in the wake of a unexpected death. Generalized anxiety disorder, again, especially at older ages. So if you have not ever experienced a psychiatric disorder before and you experience unexpected death of a loved one at older age, there's an increased incidence of generalized anxiety disorder. Post-traumatic stress disorder obviously is heightened at every point in the life course when you experience unexpected death. Social and specific phobia, there weren't many associations across the life course, which is somewhat expected. Those two disorders have incredibly young ages of onset, so there's just very little incidence of social and specific phobia in adulthood, and panic disorder was increased throughout the life course as well. So to kind of summarize some of the themes that we explored in the paper, unexpected death of a loved one was most frequently cited as a severe, potentially traumatic experience, even among individuals with really high burdens of lifetime traumatic experiences. We saw increased incidence for virtually all commonly occurring psychiatric disorders in this community sample at every single point along the life course. It's observable through childhood, through late adulthood, for major depression, for PTSD, for panic disorder. Incidence is particularly concentrated in older age groups for disorders such as mania, phobias, and alcohol use disorders. But it's worth pointing out that most people don't experience a psychiatric disorder in the wake of unexpected death. Just a note on this finding that we had about mania. If you actually look in the literature, there have been case reports about in the onset of manic episodes in intense periods of bereavement since 1890 was the first one that we could identify. And throughout the clinical literature in psychiatry, there's been this consistent documentation. There's even a name for it, which is called funeral mania, of people who, in the wake of a really unexpected separation through death, experience a first onset of manic episodes when they've never had a history of before. To our knowledge, this is the first time it's ever been documented in an epidemiological sample of this size and breadth, but certainly that suggestion has been in the literature for quite a long time, which is something clinicians should take note of, especially among older adults, even people with no history of mood, anxiety disorders, alcohol disorders. We still observe this increased incidence of manic episodes. Why do we experience psychiatric disorders in the wake of an unexpected death of a loved one? There's really kind of two different mechanisms. One is a really general mechanism that occurs for all kinds of traumatic events that we experience in our lives. A general stress pathway. Losing a loved one is very stressful. It's a very stressful experience emotionally and logistically. And whenever we experience stress throughout the life course, there is an increased risk for psychiatric disorders. The stress pathway involves cognitive, affective, and neurobiological mechanisms. But there is something really specific to the loss experience itself, having to do with theories of attachment and the role that close personal relationships play in our self-identity, in our sense of self, that losing someone who's very close to us is very destabilizing emotionally and in terms of our identity formation. So that separation distress can result in loss of self-concept. And finally, the bereavement period is really central to the human condition, and so these destabilizing periods of mood and anxiety are just part of that bereavement process. So kind of the summary of that is, rather than pathologizing or depathologizing bereavement, what these literatures together suggest, including our own research, is that we need to deeply connect with our mental health and wellness during periods of grief and bereavement, just as we need to deeply connect to our health and wellness when we're in other periods of life as well, and looking at other stressful life experiences altogether. So I'll end with a personal note. This is my son, Aiden. He's now 8, and that's his father, who died last year of suicide. And it was an unexpected death of a loved one that we experienced. And so it, really taught me something about, the challenge of parenting a child who's experiencing parental loss. And so the thing I most want to end with, in terms of what I've learned about it, is that, when we try to think about how to frame these findings in terms of public health, I don't think our goal is necessarily for people not to experience psychiatric disorders after loss. My son has separation anxiety disorder, he has post-traumatic stress disorder, he has destabilized mood, and I would say he's still a resilient kid. Resilience is not him not experiencing symptoms of psychiatric disorders after his father committed suicide. His resilience comes in me helping him and his community helping him form deep emotional connections with other human beings in order to process his grief and be open about his symptoms in a really profound way. So kind of this notion that we should bounce back quickly from trauma, or that the absence of psychiatric disorder symptoms is good or something that we should strive for in terms of building resilience in children, is a notion that I wholly reject, especially after going through this experience. And instead, I find his strength and resilience in his ability to call me during the day and say, I'm too sad to stay at school. Can you come pick me up, please? I'm really angry today. I don't want to talk to anyone. That is what makes him a resilient kid, and not that he doesn't experience any of these things or is not open to it after his experience. So I will end with that. Thank you very much. Thank you
So much.
Thanks for my time.
And in closing, we'll hear from Chris Gill.
Hi. Thanks for staying in there. It's been a long day. I appreciate your waiting till the very end. I don't have any slides. I'm going to do what I do with my students, which is to talk in metaphors and allegories, which is another way of saying I like to tell stories, so I'm going to tell a story. And I'm going to start this off by tipping my hat to a master storyteller, who you probably all know, who one of his stories began in the high and far off times, the elephant, oh best beloved, had no trunk. You probably all know this story. It's a good story. Rudyard Kipling from the Gesso Stories. Now, you may wonder, what does that have to do with grief and death and dying? And the answer is that the Gesso Stories were published in 1902, 3 years after the death of the original Best Beloved, his daughter Josephine, for whom he had written the stories. She died of meningitis. So with that, I want to take you on a different story. And maybe I could ask our colleagues over there to put it on the map. We hope this will work well. So this is a city that you don't know, I would imagine. This is Lusaka, Zambia, a city I know well. I've been working there since 2002. This is probably a couple hundred miles up in the sky from a satellite. And I want to paint a picture here. If the laser pointer works, does it work? There we go. You can sort of see that the texture of the city has big variations in it. The part of the city I know the best is this kind of greenish area. And that's the wealthy part of the city where the middle class lives. And out here, you see this less textured, kind of dense area. In fact, there's a little segment there with a lake on it. If you could zoom in on that, please, and kind of zoom us in right nice and close. Right onto this period part here. So that's one of the so-called compounds in Lusaka. These are what you would call a peri-urban slum. It is not a very big geographic area, but it is a dense area. And if you kind of zoom in even further, you can see that it is a veritable warren of sort of random roads and houses. There's no particular structure to this. You know, if you zoom out again, I would sort of call this, as a medical student, it looks a lot like histology slides, right? This looks like a slice of liver, okay? It's so dense. These are cells packed closely together. Now, a lot of children die in Chihuahua compound, and so that's why we're there. But I wanted to kind of move us over to another part of the city, right there. If you could zoom in on that, please, kind of center it and zoom in. And let's zoom straight in. This is the University Teaching Hospital, that area in the center there with a little red chevron on it. And if we keep going in and in, until we get here, there's the University Teaching Hospital morgue. Okay? And there's a driveway that runs in sort of a U-shaped here. The flatbed trucks come in with the families. They pick up the bodies. These are all coffin sellers. They load them onto the flatbeds and go to the funerals. And the morgue is here where they collect the bodies. And then right behind it, if you can zoom in even further, I don't know if you can, there's a little insignificant yellow-looking, go left a bit, right there, that thing. That insignificant-looking thing is a tent. It was purchased for us by the Bill and Melinda Gates Foundation, and that is where our grief counselors work, right outside the morgue. Okay? And actually up here a little bit, that's where our lab is. But this is where we're doing our work. Now, this is the setting in which I'm telling the story. And I'm going to ask you to switch over to the video, and don't start it just yet, but let me explain to you what you're going to see. So the Gates Foundation is very interested in saving lives. All ages, but particularly children. And one of the things that they're interested in is, are there ways we can leverage novel vaccines to reduce deaths in very young children between the ages of like 0 and 3 or 4 months? So to do that, and we're particularly interested in 2 diseases that we think are quite common and maybe undertreated, one of which we're certain is. And those are pertussis, which causes whooping cough, and a disease you probably not heard of, but all the pediatricians know about, called respiratory syncytial virus, which causes bronchiolitis. You may have heard that word. And to understand whether an RSV or a pertussis vaccine would be a worthy investment, what we need to show is that there are a lot of children dying of these 2 diseases. And that is the purpose of the study and why we're at the morgue. Because what we're trying to do is to systematically enroll every child in Lusaka under the age of 6 months who dies. And every one of them, we test them to see if they had either of these two pathogens. And if you're curious, about 10% of them do. So a lot of kids are dying of these diseases, as it turns out. Now, the study, from an analytic perspective, could not be simpler, right? It's N over N. Denominator, dead babies. Numerator, dead babies who died of pertussis or RSV. Okay? Very, very easy. But logistically, operationally, this is probably the hardest project we've ever done, because we have to enroll children and get informed consent from parents on the worst day of their lives. All right? The child is destined. This is not a particularly good time to be talking about a research trial. So we struggled with this a long time, and we thought, like, how do we do this? This is an important question to answer, but how does one actually do this in a sensitive and ethical way? And it was obvious from the start that the usual way that one does clinical research, which is to offer an incentive if they grant consent, which is totally anathema. Right? It's like paying for the child. So we can't do that. So what we decided to do was to reverse that process and offer the incentive up front, unconditionally, irrespective of whether they enroll in the trial. And the incentive we offered was grief counseling. Okay? Now, we didn't know how to do this. So we consulted medical anthropologists in South Africa. We did our homework and read everything we could about it. We consulted colleagues who'd done this, and we came up with a protocol that the Zambian staff wrote in consultation with one of the 8 psychiatrists from Zambia, whose name appropriately is Angel Chirwa. Now, the video I'm going to show you now is of one of our grief counselors, Gertrude Mananjale, under the tent, describing a particularly difficult counseling session that had just happened that day. It's very short, it's about a minute long, and you'll see the tent, and you'll see behind it kind of a white wall, which is the morgue, okay? And if you listen, and I hope we have the sound ready, you'll hear the families on the other side of the wall wailing. How does that make you feel?
Oh, it was quite emotional.
Did you cry too?
No. If we all start crying, then there will be no one to give the other the strength. So we just had to help her cry, just to provide some tissue, because she was quite broken, really.
I remember when I was a practicing doctor, in the same situation, when you're trying to counsel a grieving family and everybody's crying and you're trying not to, because you have to stay calm and, you know, but then afterwards I would go and cry somewhere else. Does that ever happen to you?
It does.
Yeah.
It does.
I don't know what else to do.
Because the only thing that we could do was to remove her from where the baby was and just to make us sit somewhere out from where the baby was.
Okay. So, a lot of babies die in Lusaka. We're not able to enroll all of them, though we are trying. We've been doing this for about 16 months now. And as of last Thursday, because we have a weekly update, the official tally is 1,052. In the same period in the state of Massachusetts, 262 kids died, of up to the age of 1. So we're looking at a mortality rate 10, 20 times higher than here. And the way that we deal with a child's death at Boston Children's, which is an excellent facility, is very intensive. There will be ethicists and social workers and psychiatrists and psychologists and family counselors who descend upon this family. And I think all with good intent and mostly with a positive outcome in terms of helping the family deal with this loss. But that doesn't exist there, except for what we're doing. So we're trying to figure out, you know, how do we learn from this unusual situation that we have stumbled into, right? Where we are doing something not unique, I wouldn't be so bold, but very unusual. And we're doing it at an industrial scale. These grief counselors are dealing with one grieving family per 5 counselors per person every single day on average. And we cover nights, weekends, and holidays too. It is a heavy load for them. And we anticipated that this was going to be very difficult for the counselors, so in advance we set up group counseling with the counselors to debrief them, recognizing that they are under a lot of pressure and dealing with a lot of sadness. And we do that as a group as well as individual sessions. And this is again with Angel Chirwa, our psychiatrist colleague. But we're also in an unusual position because we are fundamentally unsatisfied with what we're doing, in that the sense we have is that we are barely scratching the surface here. We don't understand exactly how to structure these meetings so that we can have an opportunity for an impact. These counseling sessions are painfully brief, 30 minutes. So we've created a new protocol, again, developed by the Zambian team entirely, to bring the families back for multiple sessions afterwards. An hour long, and we've created an office space for this, and we're going to be starting that hopefully in 2 weeks. We're waiting for the IRB's approval. But what we're really trying to do now is to explore the parameters of our ignorance, because we don't know how to do this right yet. We don't really know yet. We don't have a true roadmap for how to do this in the context of Zambian families. So we're kind of building the plane and flying it as we go, very halting, quite intimidating, I would say, to do this. But it seems like this is the right thing to do. And what our hope is that we may eventually, through the process of this epidemiologic study, learn something much more fundamental about life and grief, which maybe will be something that we can extrapolate and generalize and look back on the history of HIV in Zambia. And circa 2002, when I started working there, our main focus was on so-called voluntary counseling and testing of HIV, which was originally done by clinicians, mostly doctors, right? But that model very quickly proved inadequate given the scale of the problem. And so it had to be jettisoned and replaced with something much more practical and simple, which was a lay counseling session delivered by non-medical people, because that was the only way to manage the numbers of patients that we were encountering. We are hoping that we could do something similar here, where this would be a strategy that one could train not even to a nurse midwife, but to, anyone with a modicum of clinical training and exposure to the families at a critical point. And so that is where we are. And I wish I could tell you where this is going. I don't know. I don't have answers as to whether this will be effective or appreciated or impactful or change the trajectory of their grief. I don't know. But we are here at the beginning, and we're trying to understand and learn as we go. Thank you.
Thank you very much. We have time for just a couple of quick questions, but I know a few of us will stick around afterward. In closing, I'm going to ask you a couple of things. So first of all, please reach out. Everybody's contact info is available. And the reason that I'm going to ask you to really dial into and look at Chris's presentation in part, because we know that building community helps grieving people. It's the only way we're going to do it, through building empathy and compassion and understanding. We are at, I had a phone call on one of the breaks today from a chaplain at one of the military bases in the Pacific who told me, and he was frantic, and he said, Diane, suicide rates are up 60% on my base. Diane, sexual assault is up 40% on my base. What am I going to do? What are we going to do? What are we going to do? What are we going to do about the grieving military members that we have on my base? His is not an isolated case. If any of us looked at the population of survivors of suicide in our country, it's an incredible amount. These people are grieving, and yet the amount of shame and stigma. So I suggest to you that we all, as a community of living, breathing people, some in clinical care, some not, but embrace the concept that we can each become more engaged in the community of healing and the community of people that are empathetic, compassionate, caring individuals. And if you don't know what to say, do not worry. You can say nothing, but you can write it down. You can send beautiful pieces of literature. You can say, I care. But the whole point is do something. Because I promise you that doing nothing will continue the legacy that we have, which is of isolation and a lack of caring. And that's not good enough anymore. It's not acceptable. And there is no reason in our country that we continue the legacy of shame and stigma that surrounds grief. It is unacceptable, folks. The research backs it up. It shows that we are a country that needs to do more in this arena, and we simply do not have enough clinicians in our country to support the clinical care needed. And that's just grief aside from the mental health and the mental wellness issues that research bears. So I'm going to open this up for questions. Go ahead.
Thank you all very much for this presentation particularly. I actually volunteer at 2 programs in Massachusetts that have to do with families in which either a child or his family has died, or a child or a parent has died. One is called the Children's Room in Arlington, and the other one is called Comfort Zone Camp, which runs summer camps for kids. And to all of you who've experienced the death of a loved one, I want to say I'm very sorry for you. Mostly what I wanted to do was just briefly talk about the language that we use in the United States as opposed to in other countries where we talk about somebody having lost someone, or someone has passed over, or they're in a better place. This is something that we hear at our kids, with our parents and the kids too, that the person has in fact died, and that the more we can be honest in the terminology, the better and healthier it will be for the people who have experienced the death. And the other thing is for people to know that the best thing you can do is approach someone who's experienced a significant death. They want to talk about the person who's died. They want to hear what you have to say. They're thinking about that person always. So there's no surprise in your coming up and saying, I'm sorry that your child, your parent, your grandparent died. They'll be grateful to hear from you and to engage with you. And just one other thing, which is what I've learned from the work I've done, is that grief is not linear. It doesn't go and start up here and then go straight down there. That it is like a piece of, a bowl of spaghetti, that it's all over the place. That people will express grief at times when they're very surprised that it comes out. They're not prepared for it. They think they're in a good place, and then all of a sudden something reminds them of the death of the person. So for those who think, well, who say, aren't you over it yet? The answer is probably never.
So true. Thank you. Sure. Go ahead in the back.
I'm wondering, from the epidemiological end of things, how the lack of language around mourning and loss affects things. I noticed that you went and did reports on orphans and on widows, but like I'm wondering how things like sibling loss or the loss of one parent, things that we don't have names for, affect our ability to track and understand and see the kind of meaningful ways that that affects public health, even just the difference on unexpected death versus other forms of death, that like we don't really have a name for that as someone who's experienced that. Like the verbiage just to get to that point becomes really awkward, and so we're not tracking it, I think, in the same ways. And I'm wondering what suggestions you all have to be able to kind of help with that.
I mean, well, I'll just as a point of clarification, in the studies I presented, they didn't necessarily lose both parents. They could have just lost one, and they could lose a sibling too. In some of the psych epi studies, in terms of the other bereaved group, they included siblings in that. So, but I don't have any suggestions in terms of. I mean, I think that's a really good point, but I don't know what other literature.
Yeah, no, I'd be happy to. Is this on?
Yes.
Yeah, I'd be happy to speak to that. And I think this previous comment also is worth reinforcing. I mean, I think my sense is that the thing to avoid is euphemism at all costs. And, you know, there's a tremendous fear of speaking the word death. And you see it everywhere. And you see it especially, you know, I would say among clinicians, because I think it's a confession of failure. But that's what I would argue literature provides. It provides these gorgeous, lyrical, varied, and in-depth portraits of people violently, you know, extremely experiencing the emotions of grief. And of course, there are also plenty of portraits of dying that, you know, I didn't touch upon. But I guess I would say I think it's fundamentally anti-euphemistic, you know, the way powerful literature treats grief. And I think that's why it's so illuminating, and why it's so important, I think, to integrate, you know, literary works into treatment. I know, you know, the whole medical narrative field is very alert to this now, but, you know, I would say that the more, you know, events like this we can have with literary people and public health people and doctors sharing their insights about these, you know, major issues, I think the better off we'll all be.
Thank you. I think that's a good point. Chris?
Well, I was thinking about the earlier comment that you'd made, and about how it's so very difficult to see inside someone else to understand the impact of grief and how long it lingers. So I know that I still have these vivid dreams of my dad, and I imagine this is a very common experience where you wake up and you're sure that they were there in the room. It happens. When I some months ago was talking with my mom about what we were doing, and talking about this sort of exploration that we're going into around grief, I said to her, you know, one of the reasons that I'm so interested in this and feel so strongly about it is this pervasive belief that I hear that because deaths are more common in children in Lusaka, that they therefore are less impactful to the mothers of the children. Now, I hate this myth. It is completely untrue. It is, I think, a cultural conceit of ours. And I think it's probably a mechanism that we use to shield ourselves from having to think about the consequences of living in that setting. So I told this to my mom, and she said, you know, ever since your sister died at the age of 1, I have never forgotten her, 50 years later. And then she burst into tears. And she said, there are wounds that a mother will never get past. And I think that's really true. And so if there's some, you know, I'm not advocating that we try to endorse the grief of people we've never met. That's not realistic. What I am advocating for is that we dispense with this myth that it doesn't matter to them, because that's wounding.
Very true.
Chris, you're talking about a conceit. I want to raise, this may also be a conceit, but there's a fond assumption that whatever poor people living in slums don't have, they do have solidarity, and they do have strong bonds, and they help each other, unlike the developed, atomized West. And I'm wondering whether how far that has entered your thinking, whether it's true or whether it's a myth, and whether you've adapted your model in order to accommodate local conditions.
It's a really good question. I'm going to go into the same spot of ignorance. I don't know the answer. I have seen that community bonding is much stronger in many parts of Zambia than I see in my hometown. But I don't know how to quantify that, to be quite honest. And I worry about projecting upon some meaning where I have to always step back and recognize that I'm this privileged white doc living in Boston, and I haven't the foggiest idea what's really going on. After 16 years, I feel like I'm still groping, trying to understand the basic tenets of this society. I really, and I don't speak the language, and I can't go and talk to people because they don't trust me. And so everything is sort of shadows in a wall, like Plato, trying to understand what is going on here in snippets of 10-week trips to the field. I don't know.
Thank you. One last question.
Thank you so much for this this panel. And Chris, I had another. Hi.
How are you?
Good. How are you? Actually, I had another question for you.
Great to see you.
Good to see you as well. Thinking about how you are in contact with the Gates Foundation and speaking to funders who I don't know if they also knew what this project was going to go into, and I'm just wondering how it shapes your conversations with them. If this seems like an anomaly, if this seems like something that will potentially be considered in other work with other studies like yours, or how are these conversations and realities filtering up?
Yeah, our program officer at Gates, Prachi Vora, who is a BU graduate, by the way, so go BU, has been so supportive of what we have been doing and has been sharing our protocols with the other teams that the foundation has been funding to do postmortem studies in India, Pakistan, and Argentina. And then at the last RSV conference in Asheville, North Carolina, out of all places, just in November, we all got together and talked about these issues. And I'm now trying to write a paper with Maurizio Caballero from Argentina to talk about the operationalization of grief counseling in austere settings. And so this is moving around within that community. Obviously, we see this primarily through the lens of ethics. We feel that this is just intrinsically the right thing to do. Secondarily, it turns out to be an extraordinarily effective strategy for running a clinical trial because we're getting 90% consent rates. So, that tells you something. Okay, that is there a need? Is there demand for this? Apparently, yes. Okay. And then third, it is incidentally a scholarly activity that we're learning a great deal from, and we are going to write about this and think about it and try to understand it, and we're going to tell everyone about it.
So, thank you, Chris. Thank you all for another extraordinary panel. It's not easy to summarize the rich array of expertise we've heard today, but I want to highlight just a few strands that struck me, especially as a journalist, thinking of the elements of this story that we're either getting wrong or simply ignoring. One, follow the money. Tracy Balboni's image of the venture capital suits crowding the oncology sessions at a medical convention while ignoring the session on palliative care. That will stick with me. The idea that one reason we're not approaching this issue the way we should is because there's a lot of money to be made in pursuing the illusion of magical cures. Another, training of physicians. The reference by one of the questioners here to the moral injury caused physicians put in the position of prescribing treatment regimens that they know are likely futile. On us, too, Sally Tisdale's admonition to give up the myths that all of us carry as to what a good death entails, and Dan Somasi's point that the idea of a good death itself misstates the radical disconnect between life and death, that at best perhaps we can aim for a good dying. Christopher de Beleg's admonition as to the troubling side consequences of legalized euthanasia in the Netherlands, how a legal decision based on rights has served in some ways to coarsen and maybe cheapen personal moral judgment as to the value of life and approach to death. Sam Harrington's plea for a media mute on the breathless reporting of medical breakthroughs. And George Annis's plea to the public health profession to stop measuring every intervention by extension of lifespans and putting the emphasis instead on quality of life. The eloquent, poignant reminders from Abby Appleford, Susan Misruki, and Tracy Balboni that literature and religion often speak more directly to our needs in confronting dying and death than any scientific expertise. And Michael Hebb's reminder that to deal with death, we need to talk about it. And if we do so, by the way, he tells us it makes us sexier, funnier, and more fully alive. The reality and depth of grief, from the grief counselors at the mortuary Chris Gill shared from Lusaka, to the study cited by Catherine Keyes on the direct, stark relationship between the unexpected death of a loved one and depression and other post-traumatic stress syndromes that crosses all age divides, all age groups. And thanks especially to Diane and Susan and Catherine for sharing how they've worked through that grief in your own lives. I had a thought from Barbara Ehrenreich, and I know she would love to have been here today, and this is stuff that she's been thinking a lot about, and I'm sorry that she's homesick. But I spent the day yesterday, we came up early, and I read her book. I hadn't read it yesterday. If you've not read Natural Causes, it's a magnificent read, and it's full of insight on every page. One of the things that Barbara said in the book is, in giving up on preventive care, I'm just taking this line of thinking a step further. Not only do I reject the torment of a medicalized death, but I refuse to accept a medicalized life, and my determination only deepens with age. As the time that remains to me shrinks, each month and day becomes too precious to spend in windowless waiting rooms and under the cold scrutiny of machines. Being old enough to die is an achievement, not defeat, and the freedom it brings is worth celebrating. So this is the beginning of a discussion that I hope will continue, and that I certainly hope will show up in the reporting and educational outreach of the Pulitzer Center. But for now, let me thank again Sandro and his colleagues for the wonderful panelists we've just heard today, and to all of you for spending the day with us. And with that, we'll go outside and we'll take in the miracle of snow. So, thank you.